So, hello everyone. So we can start the meeting. So, it's on YouTube Live as well as Zoom also. So, Swati is being stuck at Parliament, so she could not come today. So today we have two interesting cases. First is being delivered by Dr. Chaitanya. He is a state consultant at Max Vishali, and case is being moderated by Dr. Manisha Dasi. Manisha, as you all know, एक mic दे दो मैम. So to chair the session, we have Dr. Naveen Dosa with us, and Dr. Jha will be joining soon. He is in Dharmshala right now. So from Manisha, just try to introduce our speaker and we'll start the session.
That we have interesting case of anemia, which I must share with you is possibly index case of the series, which we have this situation which we have faced in the past 24 months. We'll see as the case unfolds. The presentation is being done by Dr. Chaitanya. Dr. Chaitanya, he's an associate consultant at the Department of Nephrology at Max Vishali. He has completed his BNB specialization from Max and his primary specialty is pediatrics. So Dr. Chaitanya will be going through the details of the that we can discuss on what all we have been facing. We sharing our experience. Dr. Chaitanya.
Yeah. Thank you for giving me this opportunity to present a case of anuria. So my patient is a 20-year-old resident of Ghaziabad with no previous comorbidities, present with fever which is of high grade initially and which is not issued with the chills, and there was no diurnal variations. The fever was associated with pain abdomen, which is of 5 days, which is of epigastric origin and crampy in nature, and there was no radiating and differing pain. It was associated with multiple episodes of vomiting for 4 days, followed by loose stools, and followed by the blood in the stool from the last 2 days. So he was, for the above complaints, he was even admitted in the outside hospital, and he was being managed symptomatically because at the time of admission in the outside hospital, he was found to be dehydrated and he was being given plenty of IV fluids. And then in the investigation, he was found to have hemoglobin of 4.2 with the picture of pancytopenia with deranged LFT and creatinine of 1.79. And at the same time, he was found to be a for IgM positivity. And probing here, he has been told that he had a history of ingestion of Golgappa. So that may be the culprit in this patient. And for this, he has received 2 units of LDP-RBC, after which hemoglobin got stabilized around 7.2 grams and platelets were in the range of 60,000 and creatinine has been in the range of 1.79 mg per deciliter. And after which the patient will become anuric. The anuric phase lasted for about 3 to 4 hours. Then at this juncture, he was referred to our Max Superspecialty Hospital on 7th. So when he got admitted on general examination, he was alert awake. There is significant pallor and icterus is also seen. There is no edema, no lymphadenopathy, no rash, no purpura, no joint swelling, no oral ulcers. On vital examination, the pulse rate is around 90 beats per minute with blood pressure recordings of 126/79 in the right upper limb in the supine position, and saturations of around 90% on room air and 96% on 10 liters per minute. On the systemic examination, the respiratory sounds, examination of respiratory system with the vascular breath sounds. Per abdomen, there is no organomegaly. CNS, no focal neurological defects, and cardiovascular system, there was no pericardial lip, and there was normal heart sounds. So patient was on the Foley's catheter before IV line when he visited our hospital. So after sending all the appropriate investigations, he was started on the brospectrum antibiotics, suspecting a sepsis with a multi-organ dysfunction and the ATN and supportive measures, and was shifted to ICU. And for the above hematological parameters, he was being transferred to the LDP-RBC and epic. Coming to the negative history, for the above associated complaints, there was no history of seizures or abnormal movements, loss of consciousness, stroke, headache, blurring of vision. To rule out, we the cause to rule the possibility of TMA. We have asked all these details. No history of cough, breathing difficulty, palpitations. No history of dysuria, burning maturation, fever, chills. To rule out pyelonephritis and to rule out the renal calculi disease, we have taken the history of lawn pain and flank pain, glavulia, which is not there. And with the possibility of glomerulonephritis, with the young age group, the ANCA being least possibility, and lupus or IgA nephropathy, we have also a history of no color urine, frothy urine, or blood in urine. All these complaints are prior to the presentation, and no preceding history of skin rashes, joint pains, or oral ulcers, no hemoptysis, redness of eyes, ear discharge, or significant weight loss. This is to rule out the ANCA. The no history of ingestion of antibiotics, antiplatelets, or intake of any complementary alternative medications. There is no history of trauma or recent surgery. Coming to the provisional diagnosis, with a background of this pancytopenia and renal dysfunction. So primary we have kept the possibility of AKI secondary to the thrombotic microangiopathy. HS being the more common, which is more favorable than the TTP because the findings associated with HS, fever, blood stools, pancytopenia, active hemolysis, renal dysfunction. The points in against the TTP are being that no CNS involvement. And coming to the second possibility, we have kept as because of this background sepsis, the possibility of ATN cannot be ruled out. There is a for this the positive association being the fever, abdominal pain, loose stools, the multi-organ involvement, and pancytopenia. However, the other possibilities can't be ruled out, like renal vein thrombosis because of the pain, anuria, fever. But the blood pressure recordings were normal. There was no worsening proteinuria. There was no renal angle tenderness. So renal vein thrombosis is less like possibility. Still, the last possibility being the glomerulonephritis, the IRG and lupus nephritis, IgA vasculitis, and ANCA vasculitis. The IRGN normally presents with a presenting throat infection or skin infection with a latency period, which was not there in this patient. Hardly there is a latency of 3 to 4 days. And lupus nephritis, because of the middle age, the presentation of lupus in a young male will be very severe with the association of the pancytopenia. We have kept this possibility, but other findings are not there. The rash, joint ulcers, and joint pain, oral ulcers are not there. IgA and ANCA being the most common in the middle-aged group, this patient least likely to fit into this group. But because of this possible association of the crescentic transformation of the glomerulonephritis, where we can see the complete anuria, we have taken the history of this IgA vasculitis and ANCA, which are least possibility in these patients. But considering all the positive and negative history, these are all the diagnoses which we have kept in the mind. So for the HUS and TTP, to rule out the different HUS and TTP, we have sent this Adam TF13 antifactor H bodies and homocysteine levels. But at this juncture, we have not proceeded with the renal biopsy because considering its low platelet count and hemoglobin and ongoing sepsis. So on the investigations, on the day of admission, the ABG is which showing bicarb of around 29.4 and lactates are 1.8. The complete hemogram is showing the pancytopenia with a nucleated RBC, and if you see the hemolytic workup, the purple smear is showing hemolytic picture like anisopyclocytosis, erythrocytosis, target cells, even the cystocells, the classical cystocells of the hemolysis. All these are present, and there is a deranged LFT with raised indirect fraction. Creatinine is 4.3 when he got admitted here. This is after the fluid resuscitation and after giving the dietary administration. And the procalcitonin levels at the same time, the other samples for the infective profile, such as procalcitonin, blood culture, stool cultures, and stool PCR were being sent at the same time. Dengue, HIV, all these were negative. The complements levels and autoimmune workup were sent. The complements lower level. The C4 being the more, lower borderline. ANA, IF and LIA and ANCA, all these were negative. And the hemolytic, as told before, this is showing classical hemolytic picture. Iron profile were normal, beetles and folate were normal. Coagulopathy, there is derangement of PT and APTT, the D-dimers are normal. We can't send the urine and urine culture PCR because the patient is anemic. Coming to the course in the hospital, after suspecting this, we have subjected the patient to X-ray, ultrasound abdomen, and 2D echo. X-ray to look out any pleural effusion, any signs of consolidation or cardiomegaly. ultrasound abdomen to rule out any primary kidney pathology such as CKD, which was not there because of normal sized kidneys and maintained CMD. There was associated mild splenomegaly and lymph nodes were enlarged, but which are subset.
ठीक है लेकिन
Today, today question, ejection fraction of 55%, IVC is dilated. There is as such no pericardial effusion and there was no concentric LVHR by right ventricular pressures. So for this, the gastro and hematologist opinion were taken, and he was transfused 4 units of LDP-RPC and platelets, both STP and RDP. And for the pancytopenia, mild splenomegaly, and fever, the scrub and leptospira IgM were sent, which were found to be negative. He was started on the Lasix infusion because the IVC is dilated and he was already being given with plenty of fluids. However, his urine output did not improve and his creatinine and urea kept on increasing. And for the pancytopenia picture, without any previous history of any drugs or exposure to chemotherapy or radiation or any history of immunosuppressive drugs, the HLS has to be ruled out. So for which we have said ferritin and fibrinogen. Ferritin is slightly elevated. It is in the range of HLS more than 500. Fibrinogen is not in the range less than 150. It is less than 150. It fits into HLH, which is also not fitting. Triglycerides are moderately elevated. So all these are not fitting into HLH. And then we got a call from the ICU team. So because the patient is anuric for a long time, so they want to have an opinion. So when we saw him, he was volume overloaded. So we have initiated an hemodialysis. And we have sent us serum C4, all this as discussed earlier were negative. Blood cultures and stool cultures were sterile at this point of time. So considering the background of TMA with predominantly of HUS, and which can be a classical HUS or maybe the typical HUS, the steroid doses were given and he underwent one session of plasmapheresis on 9th and was continued on the maintenance dose of steroid. And then later on, he underwent a hemodialysis on 10th via non-tunnel right hasty catheter insertion. And thereafter, because as the hemolytic picture did not improve and the urine output has not picked up, so he was continued on hemodialysis and plex for the 5 cycles. Simultaneously, the hematology reference was taken for the pancytopenia and all the infective causes and the drug causes. After ruling out all these causes, the bone marrow aspiration biopsy was planned. We showed the reactive bone marrow, which is showing the trilinear hemopoiesis, megakaryocytic, and erythropoietic hyperplasia. And obviously, there is a left sheet bile saturation to cope up the stress. And the bone marrow cultures were also said, which are sterile. So after these 5 sessions, the hematological parameters started improving and he started producing a little bit of 100 to 200 ml of urine. But his creatinine remained high. So he was continued on the hemodialysis. Meanwhile, the workup for the TTP and atypical HUs such as ADAMS 13 and antifactor antibodies and cobalamin deficiency associated with HUS were homocysteine levels were sent, which showed normal range. And the platelets, but the TLC and platelets remained high because the initial phase, because of this sepsis, there is pancytopenia. And after a few days, as the course in the hospital progressed, the TLC and platelets increased because it can be due to the sepsis or maybe due to a steroid effect. Later on, because as the hemodynamic parameters stabilized and there were improvement of hemolytic parameters, he was shifted to ward on 17th of April. And then we have planned a biopsy on 21st of April. After the platelets have been improved more than 1.5 lakhs and the hemoglobin has been increased more than 10, there is no complement of coagulopathy and no active bleeding. And the procedure went uneventful and there was no post-procedural complications.
So we have seen how the patient presented, a young boy who had had some food outside, presented with fever, with pancytopenia, severe thrombocytopenia, polyclinic acute kidney injury. The possibilities which at the face of it, which we thought was possible, sepsis with hemophilia. Now the focus of sepsis had to be found out. Now you may call it a specialist bias because I'm a nephrologist. I'm very sensitized to HUS. A patient coming with thrombocytopenia and renal failure will always look at HUS if at all it is there or not. And timely institution of therapy can actually be life-changing or might be a game changer at the outset. The other things which we thought in the beginning was pancytopenia with acute kidney injury, history of fever, possibly atypical infections like rickettsia, leptospira. There are few things which were going against the diagnosis. Like in leptospira, commonly it's a non-oliguric AKI with hypokalemia, which we didn't have. Rickettsial fever, again, it was mine because in this area we do find some amount of rickettsial fevers also, but the test which was sent later, we found that they were not contributing. The other thing which we thought the initial bone marrow suppression was possibly part of severe sepsis only, but typhoid IgM also came positive. We are not very sure how sensitive, how specific was that. HUS has been rarely reported with typhoid, so we can't comment on that. Another important thing which he has also mentioned was HLH, where platelets are too low, there is a pancytopenia plus renal failure. That is one thing which we considered the relevant tests were done. They were not contributed. Aplastic anemia was another thing. That's why bone marrow exam was done. Aplastic anemia is associated with HUS also. Some patients with aplastic anemia have overlap with PNH, paroxysmal nocturnal hemoglobin. That's why the bone marrow exam was done without that possibility. So at the end of it, another important thing here was the complement. It was too low. T4 was okay, not bad. So a low C3 level with normal C4 as badly affected C4 would link towards involvement of the alternate complement pathway, which is the pathway which gets affected in atypical hemolytic uremic syndrome. That is why after an initial dialysis and stabilization of the patient, uh, we stuck to the guns of HUS being the thing that we are dealing with. The pointers were presence of hemolysis on a central bloodstream, renal failure, and thrombocytopenia. There were some soft pointers also like aretic count was high, indicating that bone marrow was still trying to help. Whereas there was a hemolysis happening everywhere else, but the bone marrow was still responsive, which went against that initial thought process of possibly sepsis causing everything. In sepsis, the bone marrow suppression should have a low rating. So, with these things in mind, we did start the steroids and plasmapheresis, and the patient did start responding in terms of hematological parameters. The kidney parameter was still same. They were still oligurin. That's why we did a biopsy, and it was not an easy biopsy. It was fully loaded, and we had to do in a sitting position. Biopsy did confirm the diagnosis of hemolytic uremic syndrome. This is the description. So, hemolytic uremic syndrome involves the small blood vessels where endothelial dysfunction and complement activation ultimately lead to formation of small microthrombi within the blood vessel. Obviously, the circulation is affected and it may lead to necrosis of the tissue which is distal to the circulation, which is what you see here, patchy cortical necrosis. So, the cortex of the kidney, which is the most important part, the glomeruli are present there only, the important functioning glomeruli. So they had undergone necrosis of up to 15 to 20% of the sample renal cortex, which is very significant. So the creatinine might never come back to normal, and we have to know where we are going to reach. Anyways, we continued with our plasmapheresis and other things, and did reach a decent level of, although kidney function never normalized, but dialysis freedom, which happened after a prolonged period of time. Now, why we have talked about this case is in the past, by memory, and we will be publishing this data soon, 5 patients where this was the profile of presentation. A history of fever with severe thrombocytopenia, renal failure, evidence of hemolysis in peripheral blood smear examination, complement C3 low, C4 opaque, and a clinical diagnosis of HUS, which was subsequently confirmed on a kidney biopsy. How they got triggered, three of them had some not doing contaminated water or how it has been prepared. The two of the patients had a dip in a river. And all these 5 gradually they were able to come out of that. Why it's important to know is when a patient comes like this, sepsis, MODS should not be the only thing on our mind. We should think beyond the obvious so that we can change the course of a patient's treatment. Here, a patient became dialysis free. That is a big thing for a patient. Suppose we had not done plasmapheresis or we had not given steroids, we are not sure whether he would have reached recovery or not. Where we can see the biopsy was showing necrosis of the tissue. We still can't make the necrosed tissue alive again. So, tiny thinking about things which are more than obvious it's very imperative when we are looking at a patient with multi-systemic one. That was the premise of my this case considered.
What's the
Yes, yes, because it was not possible before that. Patient had severe thrombocytopenia. Now, these platelets are functional. Like, if you go logically, patients may not have a bleeding because these platelets are working. There's nothing wrong with this. But still, why should we take this? Any which way our kidney biopsy, kidney is like a sponge of blood vessel, and you're pouring bleeding into the a sponge of blood vessel. Possibility of bleeding will always be there. So better to be safe than sorry. That's why we did start steroid first and then did the biopsy, and it was safe to do so. Again, there was another patient where we skipped the biopsy because it was not safe. The hemolytic profile of the patient picked up much later after plasmapheresis session was completed. Biopsy, as you can see, did not change our line of treatment, but it did definitely make us sure on where we were going right. So you may not be waiting for the biopsy for instituting treatment. That's what I want to say. If you're clinically assured that this is the course of illness, how it is going, you have significant peripheral evidence of an HUS, please proceed with the treatment. You'll see about the biopsy data and it is safe for the
Ma'am, I have a question. Like HUL, you said, is always an autoimmune or is it an autoimmune? Why did you start the steroid in the first place?
So HUS again, it has different types. One is a typical HUS which commonly happens after bacterial infection, which is E. coli, specific types of E. coli or sugar-like toxins. So your complement level, your complement level. In typical HUS, complement levels are not low. In atypical HUS, where alternate complement pathway is affected, the C3 levels will be very low, C4 may be slightly low, normal. This is a hint towards atypical HUS, where immunosuppression is indicated, not in the typical HUS.
You started this steroid because complement level was low and you suspected that it may be autoimmune.
Any biomarker for HUS?
So, not specifically. So there are certain biomarkers which lean towards the diagnosis, but they will not be absolutely 100%. Like complement is one of them. To give you an example, yes, C3 is low in atypical HUS, C4 is not. Or C4 may be slightly low. Then you have SLE also, in which complement levels will be affected. How do you differentiate between the two? By clinical practice, right? So we do have certain hints which may lead you towards the diagnosis of HUS. Let me enumerate them for you. If you find hemolysis on a peripheral blood smear, if you see that the red count is high, indicating that the bone marrow is still responsive, you have a renal failure, commonly oligouric associated with hypertension, which is difficult to control, and you have a thrombocytopenia. So the definition of HUS is this only: hemolysis, uremia, and as you can see on blood tests, you will see complements which are there are indirect ways of reaching them. There are certain genetic tests which would lead you towards the genetic types of HUS, but obviously not all HUS are genetic. So this is a clinical diagnosis in which you take the history of the patient plus tests which are directly towards the line of the patient.
Ma'am, one more question. Is there any HUS in which the steroids are contraindicated?
So it is typical HUS.
Or the
Typical HUS. In the typical HUS, you don't have to do anything, it gradually improves of its own. Commonly it happens after a bacterial
So
infection.
suppose in that case we would have started the steroid, it would have harmed.
It may prolong the duration of it. So this person will take more time to get it.
Sir, in typical HUS like E. coli, Shigella, we don't have to do anything. We just hydrate the patient, give the washed RBC. Don't give the unwashed RBC, washed RBC, and renal replacement therapy as per the requirement. That's it. And antibiotics are also not needed. That I am going at the take-home message. Three things should be kept in the mind in typical HUS. No antibiotics for the typical HUS. No anti-mutilating agents. No antiplatelet drugs. No anticoagulants. Nothing. Just give hydration and give supportive therapy like renal replacement therapy, which occurs in 50% of the patient may require hemodialysis in the typical HUS or in the atypical HUS. Give them hemodialysis, give them some time, they will recover. That's it.
Suppose plasmapheresis, only the hemodialysis.
That's what.
Same.
No, sir. I can't comment at that point of time because the C3 levels are low, C4 are borderline. So it means that it is a typical HOS pointing towards a typical HOS. So it is better to provide plasmapheresis. Once the renal shutdown has happened, whatever you go doesn't work. So it is
For giving steroids. Then what is the role of plasma pheresis?
so plasmapheresis is for removal of the antibodies and all the pro-inflammatory, pro-thrombotic state. Even that's what I'm saying. Antibiotics should not be given in the typical HOS. But in this cases, this is different case because in the typical HOS, which is of E. coli and Shigella, the toxin produced will aggravate the case. If you give some antibiotics, that more toxins will be released and more microvascular thrombi will form and endothelial injury happens. This is a different scenario. In this, we can give antibiotics. In fact, antibiotics prescription is allowed in certain cases of HOS, such as pneumococcal HOS and HOS like this, a typical HOS, where there is a mixed picture. You can't document in either of these. So at the initial point of presentation, there is no particular single point of investigation or the clinical marker which can say this is HOS or this is atypical HOS. So initiation of plasma exchange is definitely better and it has resulted in significant outcome.
Already. Provides an expression helps in formation of new and plasma pheresis takes care of whatever has been already formed. That's why whatever it is, the plasma pheresis required as a therapy function is commonly combined with an immunosuppression so that we can at least take care of the antibody.
So hemolysis, hemodialysis and plasma pheresis must be on the different days.
So we can do that on the same day also because plasma pheresis is kind of half of the session and standard dialysis is 4. We generally keep a gap in between when the patient has died down for 6 to 8 hours. That time
So on the different
on
days.
the different.
We were not just what is the experience of managing this HOS patient, right? Or mentioned that it is atypical HOS. So why you say that it is atypical HOS has mentioned that no CT reports in the
should have right discussed here. But for atypical, that's what she was associated with the same facts that the preformed antibodies, preformed those are already in circulation that can be removed by the plasmapheresis process and further formation is improved or stopped by reduced by steroid use of steroid or and other supporting measures. Many times we can do same day also, we can do alternate days also. If we're doing like then we do alternate days. Then depending upon the need of dialysis, if the patient is typically anuric, many of them are anuric. And it sometimes takes 3 to 4 weeks for the anuria to resolve. And many times have these patients have a partial recovery. Ultimately, also, so it's a type of AKI there, and many of the AKI should recover fully or partially. So this is one of the atypical or HUS is one of the types wherein the recovery is very sometimes partial or the kidney function the GFR will improve, but it will improve not to the tune of like 70 or 80, but to the tune of around 30, the rate is around 3 or 4 baseline. Then after the improvement. I'm not sure about this specific patient, how is the but all these patients over a period of whatever they have to recover, generally 6 to 8 weeks, many times up to 3 to 4 months, you can say late to late recovery. So beyond that, you can say this is probably become a new baseline for this patient. And all this patient will have same 3 to 5 ml of GFR for 6 months to a year. And they may go land into next 4 or 5 years or sometimes 9 years also. Many of these patients. That is one.
For atypical HUS, all the symptomatic markers should be negative, like procal, punctures.
Yes, because we are giving immunosuppression intent, so I mean, it's better that. So.
So genetic screening is available, or we should do not antibodies are there. So genetic screening is there for HUS. Just showing.
Another fact is like hemolysis is one part. I had one patient about long been around 18 years. Was basically hemolysis was there on because hemolysis was this PD deficit. So different types of hemolysis also can cause this, and that lady also was 3 weeks she was anemic. And we were perplexed. We couldn't do biopsy because the platelets are also difficult to do biopsy in those patients. We just have to wait, keep on waiting. Finally, one day she started pouring, and most of these when they recover, doubling of the urine output will happen. So today it is 100 ml, 200, 400 like that. And this patient is not still coming to me in follow For any drug, anybody writes, this will come back. Yeah, this is pretty bad. Can I take this? 200 is 1.2, 1.1. This has been one of the good performance. But many patients will have like.
Shigella, E. coli, sir, streptococcal pneumonia, Klebsiella can also cause. And there are unreported cases, so many reported cases of even Salmonella typhi, but very rare possibilities. This Salmonella typhi, मतलब this is contaminated water, sir. It can be anything, but in generally thought of it is. सर वो IgM कितना reliable है?
For typhoid goes and is better. When does it have to grow simultaneously? Typhoid IgM is not specified.
These are all post-transplant patients, sir, which are BK virus, CMV. These are all post-transplant CMVs.
One of them had a combined hepatitis A and E infection. That is one case. Second, this is one Golgappe. There's another Golgappe lady who had Golgappe. I don't know if they had same place, but she is now in recovery phase in the sense that now we are stopping her dialysis. And that was about a prolonged wait, 2.5 months. Horrific ICU course, but gradually, possibly she was young and she had in the
bacteria grow कर जाता है.
I think this is a very important point. How to work out this.
Yes. So whenever we get a case of a TMA, so always we have to send the basic parameters such as complete hemogram, including the peripheral smear, retics, LDH, and the LF2 profile, which shows indirect evidence of hemolysis, like indirect bilirubin will be elevated. The haptoglobulins will be lower, then there will be cysto size which is more than 1%. And at this point of time, definitely you should eliminate the other causes such as autoimmune hemolytic anemia, which by doing the direct womb test, and always exclude the sepsis-induced DAC, and assess the not only the renal but also the extra renal and end-organ involvement. After you have done all those things, then go for the ADAM TS13 levels. ADAM TS13 levels also, while sending this sample, you should be very cautious. This should be sodium citrate sample, and they should be done at -20 to -40 degrees. Preferably, when the lines with the heparin should be avoided, and the double centrifugation should be done. So after doing all those things, then we go send the ADAM 13 levels. If it is low, it suggested TTP. If it is normal, then go for the other tests such as stool toxins, cultures, imaging, viral test, HIV. All these viral markers, viral agents which you are seeing is BK virus, CMV. Mostly they are in the post-transplant setting. The influenza COVID-19 can happen in normal setting also, but BK and CMV in general we see in the post-transplant setting. The autoimmune screening should also be done to rule out the lupus and as well as the rheumatoid, as well as the systemic sclerosis, Sjogren's syndrome, and as well as the ANCA vasculitis and anti-GBM, because they are associated with this TMS. And the metabolic component, if you have this raised homocysteine methylmalonic acid, to think a possibility of cobalamin deficiency, and definitely do the pregnancy test. And if the patient is a pregnant, and the transplant rejection if the patient is a transplant. Then you come to the complement mediated TMA. Here, initially it used to be, it is atypical HOS, typical HOS. Now the terminology has been abolished. Now we call it as complemented mediated TMA. Complemented mediated TMA, it is genetic or acquired. Genetic, because of these mutations in the complement factors, there are complement factors which promote the alternate pathway. There are complement factors which withhold or which protect from the overactivation of the complement pathway. So this factor I, C, H, I, B, these are all promoting factors. The factor D, I, they comes in the opposite way. They oppose the alternate pathway. So by sending this genetic testing, the other complement mediated TMA is antibody mediated TMA, which is particularly against the factor H. So, and then comes the complement proteins. You can send all these complement proteins of the alternate complement pathway, and you can analyze which side we are going, whether it is genetic defect or it is acquired defect to antibodies. Anti-factor H antibodies assays also the same technique as the ADAM TS13. It should be frozen and it should be sodium citrate sample. So in this patient, we can see
due to paucity of time, I think we should conclude, and it was a very nice one. Please conclude.
take home message, TMA is a clinical diagnosis. So don't ever think that TMA can be systemic. It can be also renal limited in all these settings between transplant or hypertension emergencies or APLA. HUS, definitely when there is predominant kidney involvement or requirement of dialysis dependent. Plasmapheresis doesn't help in MCP and streptococcal pneumonia. In the HUS, avoid heparin, antithrombotic, antimotolytic agents. TTP, when there is more CNS involvement and severe thrombocytopenia less than 30,000. And the agent we generally use is capolizumab, which targets the BVF. So think in a broad spectrum of view, apart from the sepsis, look at the complement levels, look at the infective profile and the autoimmune markers, then take a decision whether to go for steroid, IVIG, plasmapheresis, immunosuppressive therapy, or just the hydration. It all depends upon the clinical scenario, not on the blood tests or investigations. Thank you.
Last message, don't please walk outside or go take those.
Yes, sir.
That was a